of URM in various conditions in the body. Over to you, Rajesh.
Hi, good afternoon everyone, and I hope all of you are enjoying the lunch. Okay, great. So I think Professor Lee has already given us a wonderful introduction to URM and how it really works. So I'm just going to show you which different clinical applications we have used it in, and there are a lot more that we can potentially explore as well. So just a step back, and if we look at how contrast has evolved over the years that we've been using it, it's actually been phenomenal, right? So this is how the initial images were. We were just getting, of course, enhancement, and it was a big thing to look at that point of time. We gradually moved on to getting these parameters on assessment, the time intensity curves, which added another dimension to what we were looking. And soon we moved to these graphical representations, which made our understanding of the pathology a little bit easier. And now we have this URM, right? So if you look at what this URM really does, you are now looking at a resolution of less than 50 microns, right? So with color Doppler, what you were looking at about, say, 200, 500 microns. With microflow, you're looking at about 100, 200 microns. With URM, you're now looking at less than 50 microns. And this is how it translates into clinical practice, right? So this is your super microflow imaging. You can see, of course, the vessels very well in the periphery of the renal cortex, but you inject contrast, do URM, and just look at the clarity of vessels. It adds another dimension to our understanding completely. So when we look at URM, there are, like Professor Lee mentioned, there are different maps we can look at, and there's different information that we can gather on it. So this is the hemodynamic map, which tells us how the contrast bubbles are proceeding in that particular frame. Then we have the density map to tell us how many vessels are there in a particular area. But what is really going to change or evolve the contrast over here is these perfusion indices, right? So we are now able to get a quantitative parameter, right? So we are not just looking at colors, we are now looking at numbers. And of course, we know that whenever we look at numbers, we are always happier because it's that much easier to convince our clinician. So if you look at the numbers that come out right now, there are a whole bunch of them, right? So you can look at the complexity levels of the vessels, you can look at the blood volume, the perfusion, the curvature of the vessels, and so on and so forth. So of course, we need to explore these applications to really see which of these parameters can be used in which appropriate clinical setting. So let's look at some of the clinical settings where we have used the URM with effectiveness. So when we look at carotid stenosis, we have, of course, been used to doing Dopplers for a long time. But with these ultra-fast CUS techniques which are available, we are now able to see these vessels far better with contrast, which was a little bit of a challenge in the initial stages. But this is where it makes a little difference to the clinical practice. Look at this. If you look at this patient on Doppler, you will definitely go ahead and say, yes, there is a complete occlusion, right? There's absolutely no flow going beyond this. And if you look at the scale as well, we are at about 3.5. So, we are at a low scale. We are trying to look at really low flow. But see what happens when you give contrast and do a URM. You're actually able to see this trickle of flow which is going through the stenosis, which we were not, right? So this is a patient who is actually in a pre-occlusion rather than occlusion. And this is what happened. The patient came back to us after 6 months, managed conservatively, and now you can see that yes, there is a definite improvement in the flow. So what was a very minor streak which was coming up over here, you can see that yes, the flow has definitely improved. So the patient is progressing in the right fashion. Now what about carotid plaques, right? This is always a challenge, looking at carotid plaques and defining them. So when you do contrast, you can still kind of make out that yes, there is probably a plaque over here, but once you do your URM studies, there's absolutely no doubt left in your mind that this is indeed an ulcerated plaque, right? So of course, the management is going to change depending on that. And then what about peripheral vessels? So we have, of course, again been looking at the peripheral vessels on Doppler, trying to look at significant areas of stenosis and narrowing. So now you can confirm your diagnosis on the URM once you inject the contrast. So similar to what we see on the Doppler, we are able to see this pre-occlusive thumb. But what is making a difference with the URM is our ability to see the collateral channels. Right, so collateral channels is something we cannot very easily identify on Doppler, but with URM, which is able to pick up this very, very minute flow which is coming through the vessels, we are able to analyze the collateral channels. And once we say that yes, there is a good collateral channel formation, again the patient is going to be conserved conservatively. And now let's talk about the liver, because this is where we indeed use majority of our contrast. Now for a long time, and up till now actually, and we still do it, we rely on our late phase to characterize the liver lesion, right? So we want to see if there's a mild washout, there's an intense washout, there's a late washout, early washout. But with the advent of the URM technology, we can now analyze the arterial phase a little better as well. And when we say analyze the arterial flow, we are not just looking at the presence of flow, but we can do this analysis, we can look at these different parameters to see if indeed this lesion is a HCC or not. So if you look at some of these patients that we have done, what we found that there's a difference, or there's an increase in these blood volumes, the maximum curvature of the vessels, and the perfusion indices in some of these cases to differentiate it from a normal liver parenchyma. So what we could potentially be using this is to identify HCCs at an earlier stage, right? And this is of course just a fancy reconstruction, but it's just to show that how nicely you can see the supplying vessels. Great. But another very, very important application of URM. Now, when we do ablations for the lesions, liver lesions, particularly HCC, of course, we want to know whether there's any residual enhancement or no. And if you go over the guidelines, we actually have LIRAD's guidelines for post-ablation management as well. But the URM really adds another dimension to this whole finding. Once we inject and we can see this flow in the periphery, you are very well assured that yes, there is definitely some flow in the periphery. This is not completely ablated. You can go ahead, measure your volumes, blood volume, the complexity levels of the ratio, and you can use this for following up these patients. So the advantage that we are doing with this is we do not need to put this patient through an MRI or a CT every time we want a follow-up for this patient. The ultrasound contrast works fantastically well. And this is just something that we tried it out on. This was a patient who had a drainage tube for a liver abscess, and we were not very sure on the ultrasound whether the drainage tube is still in or no. So what we did is just injected a little bit of contrast from the tubing, and we can see that the cavity is filling up over here, right? So again, your sensitivity is going to make a difference in these situations. And when it comes to urology, again, I would say a huge impact with contrast and URM. Of course, when we look at solid lesions, we want to identify whether they are benign or malignant. And of course, the malignant lesions will show some form of enhancement. But a large component of the abscesses sometimes can be very confusing, right? They can appear as solid lesions. So what we would like to call them is solid appearing lesions. And we want to differentiate whether this lesion is definitely a solid lesion, is it a malignancy, or whether this is an abscess. Of course, the clinical picture is going to add to your diagnosis over here, but you can see that within this solid appearing area, there's absolutely no enhancement, right? So we are rest assured that yes, this is an abscess. And even this, so this in fact was a patient who came to us for a follow-up. So we knew that yes, this patient already had an abscess, but for someone who was looking at this patient for the first time, you would probably look at and call this as a lesion. But the moment we inject contrast, we see that yes, there's only peripheral vascularity. So we can say that yes, this abscess is resolving. And a huge impact when it comes to identifying, or rather classifying, cystic lesions in the kidney, right? So we know that traditionally we have been looking at CT and MR for classifying these lesions on Bosniak, but we can now do this with our contrast as well. And URM again adds a new dimension in terms of the sensitivity. You can be very well assured whether these very fine septae are showing enhancement or no if you can track these microbubbles with URM. So this, for example, was a simple cyst, though it looked complex, but these septae were not enhancing at all, whereas here you can see that there's a thick enhancing septa, and of course your Bosniak reading changes. So we are potentially exploring at looking at these values in the solid components as well to try and identify between benign and malignant, but I do not probably have enough literature to talk about on that right now. So the other very interesting feature that this system has is this ultra glow function. Now what happens is when you inject contrast, the system is able to assess the number of functioning glomeruli in that particular area, or in the particular area that you are scanning. And this can potentially give us an idea of whether there's a reduction in the number of functioning glomeruli, and we may eventually reduce the number of biopsies we do for medical renal diseases. But again, very interesting, urinary bladder neoplasm. Yeah, once you give contrast, the enhancement is very similar to that of the wall. So when you look at it with a naked eye, it's very difficult to perceive the difference in enhancement, but see what URM does, right? So you turn on your perfusion maps and you can see that there's a clear difference between the lesion and the wall over here. So the lesion is showing intense enhancement, there's high perfusion. Again, you can go ahead and take your perfusion indices, your ratios, and you know that yes, you're probably looking at a neoplasm, and this indeed turned out to be a transitional cell carcinoma. So what about testicular torsion, right? So we have not been doing too many contrasts in the past. The reason being that you need a lot of contrast when you're looking for a lesion like testes, and you have to, of course, have very high sensitivity with your linear probe. But again, with URM, with lesser amount of contrast, we are far more certain whether the testicular parenchyma is showing any flow or no. So here, for example, you can see that this testicular parenchyma is showing minimal flow, but there's absolutely no flow coming up over here. You want to go ahead a step further, please do that. You can now quantify the volumes as well. So this gives us a very good comparison between the normal testes, which is being well supplied, versus the testes which has undergone a torsion and not supplying adequate flow. One of the questions that we are often asked with is, in undescended testes, is the testes showing flow or no? The surgeon wants to know this, and it is invariably a problem because the child is crying, you have an undescended testes, the testes is very small, located somewhere in the abdomen, and you have a hard time looking at the vascularity over here. So again, URM can come to the rescue over here. So this, for example, you can see that there was absolutely no bubbles flowing over here, but you could see there was some flow which was tracking through in the normal testes, so you are that more certain of your diagnosis. And now we even have the ability of fusing the slow microflow with the CUS, so that again gives you another dimension, another sensitivity to looking at your lesions. So when it comes to prostate, luckily now these the transvaginal and the transrectal transducers are equipped with the URM imaging as well. So we are able to look at the prostate on contrast. This is again, the diagnosis is very simple, but this is just to show how well URM can work over here. In this area which appears solid, there's absolutely no vascularity, no bubbles tracking through, so you are rest assured this is a prostatic abscess. So what about gynecology, right? So we do end up doing a fair amount of gynec work on contrast, and one of the things that we want to know is these solid areas, whether these small solid areas are enhancing or whether there is enhancement within the septae or no. And to be very sure, again, once we are able to track these microbubbles, we can definitely go ahead and say whether there's enhancement within the septae or no. Now, another huge advantage of contrast in ovarian lesions is when you want to classify the solid lesions, right? So here, for example, you have lesions, both of these are solid. In fact, this is a little more solid cystic, but when you give contrast, what you see that there's no enhancement within this area at all, right? And that is again confirmed on the URM. So this was in fact a hemorrhagic cyst, whereas this was an ovarian neoplasm. So enhancement of the solid appearing areas will again help you to identify whether you're looking at a benign or a malignant lesion. And again, now we can, since we have the quantification parameters available with us, we can probably look at the enhancement patterns in these solid areas, quantify them, and potentially classify these lesions as well in the future. Now this is, one of the challenges that we frequently encounter. We inject contrast and, sometimes for whatever reason, the enhancement is very poor. Maybe the contrast, quantity is less, or the transducer setting is not right, or whatever it may be, right? So for example, over here, once we injected, we were really not sure what exactly is happening. But once we process these images, we were rest assured that yes, we are seeing a pedicle which is coming up over here. So we are looking at an endometrial polyp. I'm not going to talk too much in detail about the lymph nodes. Professor Lee has already covered that. But again, just to show how well the contrast URM can really work, we are able to identify the difference in the peripheral perfusion patterns. For example, here we have an infected node with peripheral perfusion, but here you have a lymphoma with significant internal perfusion. But where these perfusion parameters have really helped us is in fact in thyroid. And we know the thyroid on contrast again can be challenging, because the moment you inject contrast, all you see is a flush of contrast, everything showing enhancement. So characterizing these lesions is very difficult. So if you look at the perfusion enhancement patterns, what we ended up seeing is that the benign lesions typically have a more peripheral enhancement, whereas the papillary or neoplastic lesions will have a more central haphazard kind of an enhancement pattern. So this one look at the lesion can help you to potentially differentiate between these two lesions, the types of lesions. So again, we tried this in a couple of cases and it worked fairly well. Of course, we can go ahead and look at the parameters as well. Now, when it comes to MSK imaging, inflammatory arthritis is one of the conditions that we are seeing increasingly commonly, and we rely on our Doppler parameters to say whether this patient is doing well or no once the patient is on medication. So once we have the ability to do the URM, and why it is important over here is because if you do a normal contrast, the pickup of the contrast in the synovium is going to be very, very minimal. And if this patient comes to you again after maybe 3 months or 4 months, you can't really differentiate between what you saw now and what you saw previously. Right? So again, if you analyze these parameters over here, you can use these for follow-up. And why this is important is because their drug modulation is going to change depending upon the amount of flow which is going to happen within the synovium. So breast, I haven't done, to be honest, too many cases, but what we've seen is again with these malignancies, internal enhancement which is coming up like this. So yes, that is again a very good application of URM. So in a nutshell, if we look at where this URM really helps us in clinical practice, one is of course understanding the arterial enhancement patterns a little bit better, and we are able to quantify. So again, the quantification game is going to change a lot of things in the future. I already mentioned that how the linear probes are significantly better with this URM technology, and we are able to get far more data than what we were getting previously. And once you get these kind of graphic representation, it just makes your analysis in a clinical practice very, very easy. And of course, because these probes are very sensitive, the system is very sensitive, we are now able to do contrast with lesser amount of dose, right? So if we are now doing, previously we were doing testes with like something like an entire vial, we can now bring it down to 2 cc's, 1.8 cc as well. Even livers or gynac, we are going down to 0.8, 0.7 cc and getting good results as a result of the technology. So thank you very much. Greetings from Mumbai, and hope to see all of you over there in 2029 for the World Congress. Thank you so much.
Thank you, Rajesh. We welcome the utility of URM